looking at acid-base status in the body, and we talked about acidosis, alkalosis, but of course the body isn't going to settle for that. The body wants a pH within normal range, so it's going to want to compensate for the acidosis or the alkalosis. So we'll talk about how it does that and how you identify it on the blood gas. So it says to assess for compensation when you're looking at a blood gas, the body will try to correct the acid-base disturbance, and this is called compensation. Compensation can be completely compensated, partially compensated, or it can be uncompensated. So those are the three possibilities. There's slides on each one of these, but this is a quick summary. So if the blood gas is completely compensated, the pH is in the normal range, but the bicarbonate and or the CO2 is not in normal range, with a completely compensated blood gas, we also use the term chronic. And the reason we use the term chronic is because the body has had time to fix the problem. So we say that it's a chronic problem. So anytime you see a compensated blood gas, another word you could use would be a chronic blood gas, meaning that the patients have that problem for a while. Then we'll talk about partially compensated. So partially compensated, the pH is out of range. Compensatory activity has begun. That means that the body's trying to fix the problem, but it has not had enough time to restore the pH to normal. And then there's uncompensated. The pH is out of range. Another word that you can use for an uncompensated blood gas is to say that it's an acute problem, meaning that the body has not had time to fix the problem. So acute is another word to use for uncompensated blood gas. All right, so how do we decide if it's compensated, uncompensated, partially compensated? The first thing you always look at is the pH. And if the pH is in range, then we're going to say that the ABG is classified as compensated. Now what if the pH is in range, the CO2 is in range, and the bicarbonate is in range? Then what do we say? Just a normal ABG. Do we say compensated? No, because there's no problems. So you would compensate it is for when the pH is normal, but the other values are not in normal range. So if the pH is not in range, then there's two possibilities. Either the blood gas will be classified as uncompensated or partially compensated. All right, so that's the next step that you're going to do. So if your pH is in range and the other values are not, you're going to say compensated. If the pH is not in range, now you've got two choices if the pH is not in range. You can either say partially compensated or you can say uncompensated. So if the pH is not in range, those are your two choices. Okay, so three choices altogether. All right, with a compensated blood gas, we say the pH is within normal range, but the CO2 and bicarbonate is out of range. And then it reminds you, just keep in mind, if all values are normal, then the ABG is normal. With an uncompensated blood gas, the body has not compensated for the abnormal acid base in the blood. So the pH will be out of range. If the PaCO2 is causing the pH to be out of range, then evaluate the bicarbonate level. If the bicarbonate has not tried to compensate for the imbalance, the value will still be in normal range. So what is normal range for bicarbonate? 22 to 26. So 22 to 26. So if we have a high CO2, but the bicarbonate is still between 22 and 26, we say the body hasn't tried to fix the problem yet. We would call that uncompensated.
So the acute?
And that would be acute. Yes, very good. If bicarbonate is causing the pH to be out of range, then evaluate the PaCO2. If the PaCO2 has not tried to compensate for the imbalance, the value will still be in normal range. So what's a normal range for CO2 in the blood?
35 to 45.
35 to 45. So we would have an alkalosis or an acidosis, but the CO2 is still in range. So that means it has not tried to fix the problem. All right, with a partially compensated blood gas, the pH is out of range, and the first thing you always do is try to find the culprit. So, do you know what that means? So if you have an acidotic pH, what's causing acidosis? If you have an alkalotic pH, what's causing alkalosis? So that's what I mean by the culprit. Then you look at the other value. If the other value is out of range, the body is attempting to compensate for the acid-base imbalance, but it hasn't completely done so. So it's not in range, but it's trying to go towards fixing the problem, we'll say partially compensate. All right, for this slide, it says when a pH is alkalotic, name 2 things the body can do to bring the pH back to normal. All right, what's the one thing that you can think of? You're alkalotic, so the pH is high. Hypoventilate.
That's what I wrote there.
You wrote it? Yeah. So you write hypoventilate, and then put the reason how that would help. If you hypoventilate,
To keep some CO2 in.
you keep CO2
Get
in.
rid of bicarbonate.
Let's stay with CO2 first. So if you retain CO2, CO2 is like an acid in the blood. So one way to balance alkalosis is with acid, and the two will balance each other and get the pH in normal range. All right, so that was one. And then the other one? To get rid of bicarbonate. Bicarbonate in the blood is like a base. So if you get rid of it, you're getting rid of base, and that's going to make the body more acid. All right, so hypoventilate to increase PaCO2 is one thing you should have written down. And then the other one is decrease bicarbonate by kidneys excreting bicarbonate in the urine. Do you need any of that repeated?
Yes.
So first thing, increase PaCO2 by hypoventilation. And secondly, decrease HCO3. Kidneys excrete bicarb in the urine. All right, now this slide is asking, when the pH is acidotic, name 2 things the body can do to bring the pH back to normal. Okay, hyperventilate. And reabsorb bicarbonate in the kidneys. So with hyperventilating, it's going to blow off CO2 and get rid of carbon dioxide from the body. So carbon dioxide is like an acid, and when you get rid of acid, you're left with more alkalosis. And that's what we want to try to do to get the pH back in range. And then by retaining bicarbonate, you're retaining base, and that's going to help the acidotic pH. Okay? All right, we have some blood gases to look at, and we have to classify them as either compensated, partially compensated, or uncompensated. So let's do the column on the left first. The pH is 7.48, the PCO2 is 40, PaO2 we're not looking at yet. Bicarbonate 29, base excess plus 5, and we have a slide coming up on base excess also. All right, so we always look at the pH first, and how would you classify the pH? And what's causing the alkalosis? Bicarbonate. So the high bicarbonate level is causing alkalosis. So we have a metabolic alkalosis. Now we're going to look at CO2 to see if it's trying to fix this problem. And the way to fix metabolic alkalosis would be by holding on to CO2. You know, the patient would not breathe as much. They would take shallow breaths to try to hold on to CO2. Are they doing that?
No.
Not at all. We're still in normal range. So would that be partially compensated, uncompensated?
Uncompensated.
Yes, uncompensated. So label that first one as uncompensated. I noticed that the physicians, like when you're giving them report, they don't like to hear the word compensated, uncompensated. Usually you put it at the end. What they're looking for is if you can identify the primary acid-base problem. So something like this, you would say that you have a metabolic alkalosis, and then you would add the word, it's uncompensated. So if you want to get in the habit of doing that even for your testing, that would be okay too. So first say what the problem is, and then say that it's compensated, partially compensated, or uncompensated. So the middle one, we have a pH 7.36, the PCO2 is 80, and bicarbonate is 44. So if you look at the pH, is it in range?
Yes.
Yes. So we know that we have a compensated blood gas. So what is the primary problem with this? Now when you have a pH that's in normal range, the way to figure out, well, it's in normal range. It could have been CO2 first, or it could have been bicarbonate first. Just remember that the body never overcompensates for the problem. It usually undercompensates. So a pH of 7.36 is closer to acidosis than it is to alkalosis, which would be 7.45. So we know that the primary problem is going to be acidosis. Which of those two are showing acidosis? The CO2 or the bicarbonate? Yes, so the CO2 is the primary problem here. Yeah, so it's a respiratory acidosis, and it's compensated.
So you're saying compensated because of the pH?
Yes. Can we use the word chronic to describe this? Because the body has had time to fix the problem? Any questions on that? The third column, the pH is 7.32, the PCO2 is 30, bicarbonate is 18. So pH 7.32, what is that? That's an acidotic pH. And what is the cause of the acidosis? Yeah, the low bicarbonate. So we would say a metabolic acidosis. Is it uncompensated or partially compensated?
Partially.
And how can you tell it's partially compensated?
Very good. It's not too far from the range, from normal.
Right. Pretty much stick with the ranges that are given. So if the range is 35 to 45 and the CO2 was 34, you would say it's not in range. You can't say, oh, it's close enough. Because for classifying things, it pretty much sticks to exactly in range or not in range.
Okay.
All right, so metabolic acidosis, and it's partially compensated. So the patient is hyperventilating, trying to get rid of some acid to balance out that pH. Okay. 2 and 3, and then we're gonna go through causes. Number 2, the pH is 7.24. Is that normal, acidotic, or alkalotic? Acidotic. So it wants you to write under the pH that it's acidotic. And then under CO2, write whether it's acidotic, alkalotic, and the same thing for bicarbonate. So CO2 of 60, what are you going to write? Okay, acidotic, and then for bicarbonate? Normal. It says, then under interpretation, write what it is, and then mention if it's normal, compensated, uncompensated, or partially compensated. All right, so respiratory acidosis. And is the bicarbonate trying to fix the problem? No. So that would be what? Uncompensated. So write that underneath interpretation. We'll do number 3, and then we'll get into the different causes for all these blood gases. Number 3, the pH is 7.46. Okay, so write alkalotic under the pH. CO2, normal, bicarbonate, alkalotic. So how would you interpret the blood gas? Good job. So metabolic alkalosis, uncompensated. Now we can see that the CO2 is climbing, but because it's still in range, we have to stick to, if it's in range, it's uncompensated. Okay. So you can do the rest on your own. And now we need to get into causes. Why would CO2 be high? Why wouldn't somebody be breathing normally? So it talks about hypoventilation will hold on to the carbon dioxide in the body. And that could be due to CNS depression, central nervous system depression, such as drugs. So there are drugs that affect the central nervous system, alcohol, narcotics. Those will all suppress the drive to breathe. So the patient won't be breathing as much if they've got enough on board in their body. Next one is neuromuscular disorders. When the nerve cannot communicate with the muscle and tell the muscle to contract, the diaphragm doesn't contract as well, accessory muscles are real weak. So people that have neuromuscular diseases will have high CO2s. As their disease progresses and the weakness continues. Multiple sclerosis is a good example. So eventually their muscles are just so weak because the nerve isn't telling the muscle to contract that they end up retaining CO2. They don't get rid of it as normal. So they would have a high CO2 level. Pickwickian syndrome is severe obesity, and abdominal fat pushes against the diaphragm and kind of prevents it from having its normal 1 to 2 inch movement during inspiration. So instead of the diaphragm contracting and there's so much pressure against it, it contracts a lot less. And that causes CO2 to build up. So over the years, that person will run high CO2s normally. Chronic obstructive lung disease, the airways are obstructed, so the patient can be breathing 12 or 16 times a minute, but the air is not exchanging in the alveoli because of the obstructed airways preventing air from moving into the alveoli and back out again. So they'll tend to hang on to CO2.
One more time, the air is not. What did you say for that? The air is not.
With chronic obstructive pulmonary disease, even though the person is breathing a normal respiratory rate, the air exchange at the alveolar level is less. So less air gets to the alveoli, and less air leaves the alveoli because of the obstructed airways. All right, so with CNS depression, neuromuscular disease, Pickwickian syndrome, chronic obstructive lung disease, of any of those, would you expect the body to try to fix the problem by retaining bicarbonate? Which ones? COPD.
And CNS depression.
From drugs?
Yeah.
No, because that's kind of like, you give a dose, or you drink too much, and then it happens. So that's an acute problem. Drug overdose. Yeah, so neuromuscular disorder, Pickwickian syndrome, COPD, those are going to be chronic. But overdosing a patient with medication, or if they're a drug overdose themselves, then that's going to be an acute problem. They take it, and then within an hour or so, now they're retaining CO2. How low will the pH fall for a given increase in PaCO2? And it tells you the answer. 0.08 for every 10-4 rise in CO2. So it gives you an example to figure out so that you can understand it. Let's say the CO2 rises from 40 up to 50 torr. It's 10 torr higher. How low will the pH fall? So you started at 7.40, and as you retain CO2, pH is going to drop. It's going to drop 0.08 for every 10 torr of CO2. So what's 7.40? What would it be now?
7.32.
Yeah, 7.32. You want to do another one?
Sure.
You okay with that? What if the CO2 drops? Instead of it being 40, it drops 10. What would you do to the pH then? Add 0.08. So what would the pH be if the CO2 is 30 instead of 40? So write down 7.40, add plus 0.08, and tell me what you get. 7.48. Okay, good job.
That's cheese.
Is that why you struggled with it? I understand that. All right. So the kidneys will retain bicarbonate ions to keep the ratio of bicarbonate to CO2 20:1. So it shows an example of acidotic blood gas on the left. The pH is 7.33, the CO2 is 59, bicarbonate is 30. So we have well, I want you to tell me actually. Is the pH in range? Is it alkalotic? That's right, acidotic pH, what's causing the acidosis? Is it the 59 CO2 or the 30 bicarbonate? The CO2. All right, so it's a respiratory acidosis. Is the body trying to fix the problem? Yes. But has it done so? No. So is it uncompensated or partially? Partially compensated. So respiratory acidosis, partially compensated. And what about the blood gas on the right? Respiratory acidosis, and it's compensated. Very good. So the kidneys have had time to retain bicarbonate, keep bicarbonate in the blood, and now it can balance out that ICO2. And then causes of respiratory alkalosis would be hyperventilation or breathing a lot and blowing out a lot of carbon dioxide. So why would that happen? It gives you anxiety, fever, stimulating drugs, or pain injuries of the central nervous system. You see a lot of head traumas coming into the ER and they're hyperventilating. Why? Because that's the response of the brain to trauma is hyperventilation. So there's more causes. Hypoxemia. But how low does hypoxemia have to be? PaO2 less than 60. PaO2 less than 60 will stimulate breathing. There are lung receptors in the lungs that when there's inflammation, it causes the person to want to breathe a lot. It can happen with pneumonia. It can happen with pulmonary edema. So, why is this person breathing so much? And then you see that they have a pneumonia, or you see that they're in pulmonary edema. And then the last one, we do this to the patient, where we put them on the ventilator, we put in a tidal volume and a rate, and we give them too much minute ventilation, and we draw an arterial blood gas, and the CO2 is really low. It's like, oh, it's too high of a rate for them. We have to either turn down the rate or turn down the tidal volume. So overly ventilating a patient with a ventilator, we'd be blowing off too much CO2. And then in your notes, I want you to write the difference between tachypnea and hyperventilation. For tachypnea
and what, sorry?
and hyperventilation. For tachypnea, that just means breathing fast. So that's something you observe when you're looking at the patient and you check the respiratory rate. That's tachypnea. Just a fast respiratory rate. Hyperventilation, you need to know the ABG to say this. Hyper, H-Y-P-E-R, hyperventilation. You need to know the arterial blood gas in order to say that a patient is hyperventilated. Wow.
Very animated.
Yes.
One
All right, so let me explain. It's possible that a person could be breathing 30 times a minute, and you can get a blood gas and the CO2 is 40. So you could say they're tachypneic, but you don't know if they're hyperventilating until you get a blood gas. And you see that the CO2s are lower than normal and they've got an alkalotic pH. Then you can say they're hyperventilating. Does that make sense? So you can't really look at somebody and know what their CO2 level is. All right, there's a blood gas here, 7.57 pH. The CO2 is 25 and the bicarbonate is 22. What is that? It's a respiratory alkalosis. And is it compensated, partially compensated? Uncompensated. So the kidneys can compensate for respiratory alkalosis by excreting bicarbonate in the urine. And it's a slow process. It may take hours to days. I remember like a 16-year-old girl was a drug overdose, came into the ER, and we did a blood gas on her, and by the time she had taken the pills that she had taken, to her family bringing her into the ER, she was breathing really fast, drew a blood gas, and already her bicarbonate was way down, trying to compensate for the fast rate. So it can take a few hours, or it could take several days. The pH on the left, 7.48. The CO2 is 25. A bicarb is 21. How would you classify that blood gas? Okay, respiratory alkalosis.
Partially compensated.
It's partially compensated because bicarb is no longer between 22 and 26. It's trying to fix the problem. And then on the right, you see the pH in range, but the pH is on the alkalotic side, so you know that the primary problem is going to be whatever caused the alkalosis. So that would be a respiratory alkalosis. And since the pH is in range, we would say compensated. It's a compensated blood gas. Wow. We're ready to move over to the respiratory lab for the rest of the semester.
Is that where all our classes will be for the remainder?
Yes. All right, with metabolic acidosis, what's causing that? It's caused by an accumulation of fixed acid in the blood. It could be lactic acid. I know everybody knows what lactic acid is, right? You got it right in the test. So what causes lactic acid? Anaerobic metabolism, is that what you said? Okay. So there's lack of oxygen being utilized in the cells, and the byproduct is lactic acid is formed. And that can accumulate. So if you have poor blood flow and you're not breathing in enough oxygen, you're going to be producing lactic acid. And then ketoacidosis, did you get that right? That's when glucose can't be utilized by the cell, so diabetics.
Yeah. Am I crazy? But this stuff was on the test we just took, right?
Yeah, so you should recognize this.
But were we supposed to know it?
We learned it in the last one.
Yeah, that's on the last one.
Oh, no, I know the acids and things like that. It was just a couple of questions on some of the other slides that I noticed that's on in this packet.
Yeah, we've talked about acid base already, so these are things you should. And then excessive loss of bicarbonate. So that can happen. Do I have it on a different slide? No, I don't. Excessive loss of bicarbonate happens with diarrhea. So with a lot of diarrhea, bicarbonate is lost from the GI tract, and the result is that you have loss of base, and then you end up with acidosis. So the two causes, either losing bicarbonate from the body or having fixed acids in the blood. There's a way to distinguish which one it is, and it's by using the anion gap. So what the anion gap is, anytime you have a patient with metabolic acidosis, you're trying to figure out what is the cause of the acidosis. Do we have gain in fixed acids, or do we lose bicarbonate? This is what you're going to do. You're going to add up the positive charges of the electrolytes and the negative charges. So the ones that are routinely looked at are sodium, potassium, chloride, and sometimes bicarbonate. I don't see them. No, I'm sorry. Yes, bicarbonate. It gives you the normal ranges. So normally sodium in the blood is 140 milliequivalents per liter, potassium 4.0, chloride 105, and bicarbonate is 24. And it's the potassium that's generally ignored when you're figuring out the anion gap. So if you want to circle potassium and just write yourself a little note, you can ignore this value when figuring out the anion gap.
in the equation?
Right. So the anion gap is when you add up the positive ions and then you subtract the negative ions and you see what the difference between the two are. So I want you to calculate the normal anion gap. So all these values that were just given to you, you got sodium, you can ignore the potassium, and then for chloride and bicarbonate, add those two together. What is that, 129 for the negative numbers and 140 for the positive numbers? Comes out to be 11, difference of 11 milliequivalents. And the normal range is between 8 and 16 milliequivalents per liter. So the normal range, 8 to 16 MEQ / capital L, so milliequivalents per liter. So the anion gap will increase in the presence of fixed acids. So if you subtract those numbers and you get larger than 16, it's because of an increase in fixed acids. Does that make sense, or do you want to rewrite that? It says the anion gap increases in the presence of fixed acids. So if there's an increase in lactic acid and keto acids, when you subtract those numbers, it's going to be larger than 16.
Greater than 16 presence of fixed acid.
Yes. Greater than 16, presence of fixed acids. The anion gap is unchanged with the loss of bicarbonate from the body. So that person that has diarrhea and they're losing their bicarbonate, they're not going to have an increase. It's not going to be greater than 16 for them. It'll still be normal. And the reason is when bicarbonate is lost, chloride is retained. So that sentence tells you this is because chloride ions increase to keep the anion gap in normal limits.
You said bicarbonate was lost?
Yes. Yeah, if bicarbonate is lost, you're not going to see a difference in the anion gap. Students were getting an anion gap last week of 6 and 7. And they're saying, well, what does that mean? It doesn't mean anything. So the only thing we're looking for is if it's a normal range, then we're not going to say there's a gain in fixed acids. If it's higher than 16, then we probably have lactic acidosis or ketoacidosis. So does this help you? This is like a little picture showing the positive ions and the negative ions and what it looks like normally. So normally we have sodium, 140 milliequivalents per liter. And of course there are positive and negative ions in the blood that we don't measure with our lab values. But they equal each other, so we just ignore it. For the negative ions, we see chloride, we see bicarbonate. Normally the difference between them is 11, just like you calculated. Okay, so let's go over here where there's metabolic acidosis. So we figure out the anion gap. We take the sodium, we subtract the chloride and the bicarbonate. In here we see there's a difference of 23. So we come to the conclusion that either we have increased acids or we lost bicarbonate. Which one would you come to the conclusion? Increased acids. Yeah, increased acids. This one shows loss of bicarbonate. So chloride has built up to offset the difference, and when you subtract, you come up with a normal anion gap. So if you have metabolic acidosis, you figure out the anion gap, and the anion gap is normal, what are you going to say? Loss of bicarbonate from the body. And then it sums it up.
If it's normal,
Yes. Normal anion gap, loss of bicarbonate. You have just drawn an arterial blood gas from a patient, and the results show the patient has metabolic acidosis. Determine if it is caused by a gain in fixed acids, like lactic acid or keto acids, or is it caused by a loss of bicarbonate, as what happens with diarrhea. Sodium is 140 milliequivalents per liter, chloride 117, bicarbonate is 11. Loss of bicarbonate. Loss of bicarbonate. Did you know right away because you saw the high chloride level, or did you add up the negatives and the positive?
That's why
Is what normal? Yes, the sodium is normal. And then you add up the negative, the chloride and the bicarbonate, it comes to 128. So when you subtract 128 from 140, you have a difference of 12, and that's considered a normal anion gap. So if the anion gap is normal, what are we going to come to the conclusion of? Gain in fixed acids or loss of bicarbonate? Loss of bicarbonate. So upon drawing an arterial blood gas, analyzing the results, you determine if the patient has metabolic acidosis. How can you determine if the acidosis is caused by a loss of bicarbonate and diarrhea? A, the anion gap will be normal. B, the anion gap will be increased. C, the chloride level will be increased. Or D, both A and C. Yeah, the correct answer is D, so circle D. You're going to have a normal anion gap. When you look at your chloride level, it's going to be high. Just the same one?
Fixed acids.
Oh, an increase in fixed acids, it's asking. So how can you determine if the acidosis is caused by an increase in fixed acids? B. The anion gap will be increased. So circle B. So with metabolic acidosis, we have a loss of bicarbonate, and what can the body do to fix that? If you don't have enough bicarbonate around and you've got an acidotic pH. Yeah, so breathing rapidly. Hyperventilating is going to fix the problem. So here we have a pH of 7.1. The CO2 is 20, and the bicarbonate level is 6 milliequivalents per liter. Yeah, so that's a partially compensated blood gas. Metabolic acidosis. And then on the right, the body is able to fix the problem when we see that the pH is in normal range. It's on the acidotic side, so we look for the cause of acidosis, and it's the low bicarbonate. So it's a metabolic acidosis, and then we say that it's fully compensated. Another way to treat metabolic acidosis, we see this a lot with sepsis. Like if a patient is in septic shock, they have usually a huge bicarbonate deficit and metabolic acidosis. And sometimes they'll even start them on a bicarbonate drip, because just to give them a bolus of sodium bicarbonate, an hour later, they're acidotic again. So they'll actually start a bicarbonate drip just to keep the bicarbonate going in and try to help the body recompensate.
Why does that happen?
Why does it happen with septic shock?
Yes.
Massive infection in the body, there's production of, there's utilization of a lot of oxygen, lactic acid gets produced, probably more than anything.
Okay, so that's why I have a low reach on bicarbonate.
Yes. The second bullet tells you that sodium bicarbonate used to be given routinely during cardiac arrest to correct for the lactic acidosis of tissue hypoxia. So patient's heart stops beating. You're part of the code team at the hospital, so you do airway, you're doing compressions, an arterial blood gas is drawn during the code, and it comes back with a metabolic acidosis. Well, it's because the blood wasn't circulating, so the cells trying to stay alive are anaerobically producing lactic acid, and then it's the lactic acid that lowers the pH of the blood. So what they would do is, you draw the blood gas, they look at the blood gas, and then order sodium bicarbonate to be given. However, sodium bicarbonate affects the neurostats of people that recover from cardiac arrest. When sodium bicarbonate is not given, they do better neurologically. So stepping backwards, they found out that the sodium bicarbonate was infusing into it was crossing the blood-brain barrier and actually worsening outcomes. Does it say here why? It just says that it diffuses into the cerebrospinal fluid and worsens patient outcome. So sodium bicarbonate during CPR is no longer done. Sodium bicarbonate will combine with the hydrogen ions and produce carbon dioxide as a byproduct. The carbon dioxide rapidly diffuses into the cerebrospinal fluid and worsens patient outcome. So it's not the sodium bicarbonate worsening it, it's the CO2 that gets produced. And that's what's worsening it. But I need you to add another note to that. So that's cardiac arrest, where you don't have a good blood flow. But what if the patient does have a good blood pressure? Can sodium bicarbonate be given? And the answer is yes. So this is what you can write down. Is BP adequate? Blood will flow back to the lungs. And CO2 will be removed. All right, does that make sense so far? So if you have a good blood pressure, you don't have to worry about giving sodium bicarbonate because now the CO2 that's produced is coming back to the lungs and getting exhaled. So good blood pressure. And then also, so good blood pressure, base excess less than -5. Do you remember the less than sign? If base excess less than -5, sodium bicarbonate will be ordered. So NaHCO3, sodium bicarbonate, will be ordered.
That's the negative one?
-5. Now we're into metabolic alkalosis, and I think we'll stop after that. All right, with metabolic alkalosis, why are we having low bicarbonate in the body? No, I didn't say that right. With metabolic alkalosis, why are we having loss of acids from the body and leaving us with an alkalosis? So the first bullet tells you that vomiting or nasogastric suction can cause this. So typically what happens is when a patient is intubated, there's a big concern that the acids that are in the stomach can be regurgitated to the esophagus. It can find its way past the endotracheal tube and get into the lungs. And acid in the lungs really damages lung tissue. So the concern is it's not good to have acid in the stomach, so most of the time when patients are intubated, an NG tube is also passed. And then the NG tube is connected to suction. And the acids from the stomach are suctioned out. Well, that creates an imbalance in the body because you've just removed a bunch of acid from the body. So now you're left with alkalosis. So that's the first bullet. The second reason why you see metabolic alkalosis is because diuretics are given. So patients are retaining a lot of fluid, and to get rid of the fluid, a diuretic is given. But with a diuretic, there's loss of potassium from the body, and it causes low potassium. It can also cause low chloride. It's probably the most common blood gas that you see in the ICU is metabolic alkalosis. Patients that are on low salt diets, they're told that to try to control the amount of fluid retention that they have and hopefully help their blood pressure. So they're placed on low salt diets. Low chloride again. Oh, wait a second. I guess repeating it twice. Here it says hypochloremia, and here it says loss of chloride. You realize they're both the same? Here it says loss of potassium, here it says hypokalemia. Those are both the same. You want to connect them with an arrow or something, or do you already know that? So low potassium, low chloride. And then the other time that you see metabolic alkalosis is when the kidneys are not functioning well. And that's, again, really common to see in patients in the ICU where their kidneys aren't working well. And then there's a sentence to write down. We've got 2 more slides, guys. Hang in there. To conserve potassium, kidneys excrete hydrogen ions. Kidneys excrete hydrogen ions, H+ ions, in their place. This causes loss of acid from the body. This causes loss of acid from the body.
So kidneys excrete what ions?
H+ hydrogen.
Okay.
Got that? So that if you're asked, why is it that patients on diuretics will have metabolic alkalosis? What is the mechanism for that happening? And that's what you would explain. Well, the kidneys need to hang on to all the potassium they can hang on to, so instead they get rid of hydrogen ions, and now we're left with an alkalosis. So that's how you would explain that. All right, so compensation for metabolic alkalosis. The body will compensate by hypoventilating. So that means the person will breathe less in order to retain carbon dioxide. So breathe less to retain carbon dioxide. I'm glad that's not distracting you. I'm glad you can still hear me. Now I know it works. All right, so metabolic alkalosis, the body's going to hold on to CO2, but we'll hold on to as much as possible to get the pH normal. And the answer is no. It'll hold on to some CO2, and let the CO2 get up to 50, but that's it. Factors that limit compensatory hypoventilation, and then it kind of explains that in more detail. The patient's not going to hypoventilate if they've got edema in their lungs, fibrosis in their lungs, vascular congestion, same thing as edema, pneumonia. So all of these reasons, they're not going to try to retain CO2. Is that it? Oh, no, you've got to interpret a blood gas. Tell me about the blood gas on the right. What is the acid base? Can you just say alkalosis?
On the right?
Which one, right? Okay.
Left.
Oh, left.
Did I say right? My brain thought left. So do you just say it's alkalosis, or do you have to say more than that? Metabolic alkalosis. Uncompensated.
Yeah.
Okay, very good. And tell me about the blood gas on the right.
In range.
But it's more the
It's more to alkalosis, and it's metabolic.
All right, so how do you know it's not the high CO2 causing the pH to be?
Because it's higher in trace that.
metabolic.
Because the pH is closer to alkaline.
Yes, so you know the primary problem is going to be whatever's causing alkalosis.
Yeah.
All right, so you have a metabolic alkalosis that's compensated. Right, the body has retained enough CO2 to compensate for it. Should I tell you what base excess is so that when you're going through your handout, you're going to be able to interpret it? Oh, there's more. Must have added to it. Oh, here we go. Base excess is a number. It's a calculation that the blood gas machine will spit out. Yeah, we can go through those next week. I just wanted to tell you about base excess before we go. So base excess is a calculation that the blood gas machine does. So you put in the blood into the machine and it gives you a bunch of values, and one of the values is the base excess. And before I read the first bullet, it says that a normal is plus or minus 2 milliequivalents per liter. So if the bicarbonate is, we say the range is 22 to 26, 24 is in the middle. So usually if bicarbonate is 24, it'll say the base excess is 0. If the bicarbonate is 26, it'll say plus 2 for base excess. So usually that's how you can almost tell what the base excess is going to be, by looking at the bicarbonate level.
You can start at 24, you said?
Start at 24. So if the bicarbonate is 20, what do you think the base excess would say? -4, because if you start at 24, it's 20, so it's probably going to say a -4 base excess.
So you start at 24 with 0?
Yes. So if the number is lower, then you say you have a base deficit, and if it's higher, you say you have a base excess. And then the first bullet, so this is the definition from the book. Base excess is obtained by exposing a blood sample in the laboratory to a gas with a constant CO2 of 40 and observing the acid or base required to bring the blood pH to 7.40. Yeah, me neither. So base excess is used a lot, like in the open heart unit. The patients come back from open heart surgery, and after being in surgery, they're on the heart lung bypass. Their hemodynamics aren't that good, so they're going to look at base excess, and then they determine whether or not they're going to give sodium bicarbonate. So if it's usually -4 or more, they're going to give sodium bicarbonate. Less than -4 is sodium bicarbonate.